Good afternoon, everyone. My name is Gary Niederprun, and I am the chairman of the board of the Mount Sinai Health System. And I'd like to welcome all of our guests today, and we're excited to try this new forum. Sinai's been on the forefront of innovation for years, so we wanted to use this as another reason to keep that continuum. It's my pleasure to welcome everyone, and to also to represent not only the board of directors, but also the 4,000 employees that we kindly call caregivers, because they do care about giving to our patients. I have been associated with Sinai for about 17 years, 12 of which has been on the board. And I used to work at Ryerson Steel. I was a senior executive at Ryerson, and for those of you who aren't familiar, it's literally a block that way. I mean, it's about a 1-minute walk. And what happened was I used to come by this neighborhood all the time. So I used to drive down Ogden, see Sinai for the first several years, because I'm not from this area. And it was sort of interesting. At Ryerson, everybody sort of came to work, and we had about 4,000 employees there too, by the way. Came to work and went, and yet this place always intrigued me. It was always like a hub of activity. There was vendors outside, there was people always mulling around most hours of the day. And so as I got more situated being in the Chicagoland area, I took more of an interest as to why is this place such a hub of activity. And I knew that something special was going on here. And I learned that there's a lot of connections, not only with the hospital and the various hospitals we have, the Schwab Rehabilitation and with Holy Cross, but that there was things like the Sinai Community Institute, where we have a lot of programs for those in our community, not just when they're sick, but helping them when they have other issues that they need to deal with. So it really is truly a community hospital. I learned that the connection Sinai has with the community in terms of identifying what are now known as determinants of healthcare and health disparities, and acting on that information was astounding. And as I got on the board, I started to understand that the research that they do, not only do they do it, but they also try to figure out what is it that they need to do to eradicate, whether it's diabetes or asthma or these types of things in the community. I also learned in my early years that Sinai is no stranger to innovation, and during its history hosted applied clinical research. Even today, our residents have an annual research competition, and many of the Sinai Group physicians serve as faculty in other areas, in other medical schools here in the Chicagoland area. For all of the issues, Sinai always embraced its challenging population, whether it be external constraints such as literacy, English as a second language, and of course financial resource limitations. We always embraced everybody that came in the door. And I remember one time when I was first on the board that a doctor, it happened to be an ER doctor, he'd been there for 20-some years, and he said that he never had to do anything at all with filling out a form for anything. His primary thing was making sure that we could take care of the patients. So we really do innovate to obtain the best healthcare outcomes for those we serve, and those we serve is everybody that walks through the door, bar none, and we're very, very proud of that. This afternoon, we're going to hear our guest panelists and moderator talk about innovation. As I turn the program over to the Sinai Health System's president and newly named CEO and president, Karen Teitelbaum, I was actually the first public time I've had to introduce her, so Karen, congratulations. I challenge all of us, as she will too, to think about innovation in all the context of contemporary health reform and the communities in which we serve, Chicago and the southwest sides of Chicago. That means with all the opportunities and challenges of the Affordable Care Act and the characteristics of those we serve. So for the first time, I'd like to introduce Karen Teitelbaum, the CEO.
Thank you, Gary, and thanks so much, Steve Gould and our panelists. We are so excited to have you here, and I'm just going to take a minute because I can't wait to hear what the dialogue is. So Gary kind of teed this up very, very well. We talked about Sinai and innovation, and there are a lot of times where people say, really, Sinai and innovation? But you've got 60% Medicaid, and you've got, right now, 15% of your patients have absolutely no insurance. And there's, I think, a misconception about linking a very challenged resource environment with the idea of innovation. And Sinai really is no stranger to innovation, and we've had to do that, I think, since our inception, in no small part because of necessity, but really more because the way that we deliver care is the right way. We keep people healthy out in the communities, which we've done for, I think, for as long as we've been open. And that's exactly the way under healthcare reform we want to be delivering care, keeping people out of the hospital healthy where they live. And we had community health workers before that was even a recognized term. We have navigators who are out in the community helping people to understand how to access the healthcare system. And all of that is exactly the way we need to be delivering care in this new environment. So even though it's not high tech yet, we really have been innovating for a very long time. And it's a really exciting time to be at Sinai because there is so much opportunity under how healthcare is now going to be delivered, not only here, but of course across the nation, and the opportunities for us to really learn how to leverage technology. So again, we're so glad to have this wonderful distinguished panel of thought leaders on this topic, and I think that we're all going to really walk away with a different view of how healthcare technology can be levered. So what I'd like to do now would be to introduce someone I consider a colleague and who has become a friend and someone I respect very, very much. Couldn't be more grateful to have Dr. Stephen Gould here with us. Steve is the founder and principal of Gould Consulting Group, which provides advisory services to companies, universities, and venture investors seeking to develop and capitalize on biotechnology and life science innovations. Dr. Gould also serves as the interim executive director of Chicago Innovation Mentors, is a member of the board of directors of Matter, and is the entrepreneur in residence at U Chicago Tech. So with that, let me turn this over to Dr. Gould.
Thanks, Karen. It's a pleasure to be here. In the way of intro, Karen and I have become good friends. She first spoke to me during the summer and said, we're going to have our annual meeting. I want to do something different. I'd like to focus on innovation. You're involved in a bunch of things. What do you think about the program? She said, I think that's great. So Sinai, as we've heard, I actually, in earlier life, I was chief surgeon at Michael Reese, the other Jewish hospital in town, so I understand the mission well. Reese, for those that don't know it, had a long, distinguished history. It's gone, so I have tremendous admiration for Sinai staying alive and staying current and reinventing itself and being committed to the cause that was the basis of its inception 100 years or so ago. Congratulations to all of you. So I am a surgeon. I began that way. I got into this whole innovation entrepreneurship thing with a team of colleagues that we were doing research. We formed a biotech company a long time ago before everybody talked about innovation. And what I said to Karen was, Sinai is sort of at the forefront in terms of the delivery, the real delivery of healthcare in an urban setting, which is a huge problem today. And the Affordable Care Act has given us all sorts of new challenges and opportunities. But I said, this is an incredibly exciting time in Chicago for healthcare innovation. And let me introduce this very distinguished panel. I'm just going to introduce their names, and then I have a few remarks, and they're going to tell you more about themselves. So I start with Steve Collens, who's the CEO of Matter, which you're going to hear about. Eric Langshur, who's the CEO and founder of AVIA, who's involved here at Sinai. You're going to hear about Eric. Eric's been very distinguished in healthcare innovation in a variety of ways. Scott Vold, who's a young entrepreneur, doing something very novel that has a direct impact on healthcare delivery. And John Vozenilek, who is the Chief Medical Officer at the JUMP Simulation and Education Center in Peoria. This is a state-of-the-art, world-class facility. John was at Northwestern on authority and simulation. And so we cover the gamut here. Not everything we're going to talk about is immediately applicable to Sinai, but I want to show you what's going on. So I mostly have pictures here. I got a bunch of slides, but they're mostly pictures. Well, the time is now here in Chicago. So
what is innovation? I sort of made up this slide a few months ago because everybody's talking about innovation. I think a lot of people use the term incorrectly. I want to distinguish between invention and innovation. So innovation in healthcare includes therapeutics, which are drugs and biologics. It includes devices, diagnostics, healthcare IT, and healthcare services. The world I live in is primarily with things that are invention, they're research, and that's what we call invention. So researchers create something, they create something that may become a product as an invention. It's not an innovation until it's out into the world. And so the definition that I like, innovation is turning dollars into products. You use research grants, investment dollars. Invention is turning products into dollars. And it's not really an innovation until it's out in the world and has the ability to impact people. So the goals of innovation are to aid mankind with all of the things we've just heard about. You want to enhance the reputation of the researcher or the institution. You want to bring it to market. That generates returns. And in a perfect world, we'll use that to perpetuate the cycle. So those dollars, it's not just about commercialization for gain, is to reinvent the system. So today, as I said, we have a lot of challenges and opportunities. The Affordable Care Act, in terms of access, expanded access is great, but we're learning there are some challenges to that. We have the opportunity to improve outcomes and reduce costs, but there are challenges. Funding for innovation is a major challenge, particularly in those that are more research-oriented in the early stage to demonstrate what's called proof of concept. And lastly, for those that are regulated, most of the things I mentioned come under regulation, either the FDA or CMS or something else. We need to deal with all that. But the goal is to get our hands around all those things and advance healthcare delivery for everyone. So that's all what has led to this vibrant and expanding entrepreneurial ecosystem in Chicago. And I really just want to highlight a few of them. So Karen mentioned I'm presently serving as the interim director of what's called Chicago Innovation Mentors, or SIM. We're about 4 years old. Our goal is to develop entrepreneurs and ventures. We really are a consortium, primarily of the universities shown here. It's the tech transfer offices who want to cultivate entrepreneurship on the campuses and move the research discoveries forward out into the real world so those inventions that I mentioned really become innovations. So our goals, we'll go through this quickly. We want to foster innovation, catalyze commercialization. These are all pictures of some of our meetings and efforts. Strengthen the entrepreneurial ecosystem. These are a couple of our ventures that have won business competitions and got sizable checks. We think we're really advancing that cause. Enhance local economic development. A couple of them have got major publicity in the Wall Street Journal, the New York Times, opening the bell at NASDAQ. But importantly, we want to embrace risk-taking. I love this quote from Jeff Bezos. The concept is entrepreneurs need to be nimble, they need to learn fast and learn often. Some people say fail early, fail often. I like to say they learn fast, learn often. I want to put a positive spin on it. Entrepreneurs need to be tenacious, resilient, resourceful, but realistic. And so that's what we're trying to bring. So we think that SIM's making a difference. In our 4 years, we've accumulated a mentor pool of nearly 200 individuals in the life science area. Importantly, we've had over 120 ventures come through in all of those areas. Those companies have raised over $30 million, which is pretty good for the first 4 years, and there are new initiatives that we're seeking. So that's about SIM, but there's a lot of other things going on. 1871, which you're going to hear about later today when Howard Tolman speaks. TechNexus is another sort of tech incubator. The University of Chicago is starting its own innovation program called the Chicago Innovation Exchange. It's formally opening next week. Matter, which you're going to hear a lot about. Steve's going to tell us about that. It's the next generation. The mayor formed what's called Chicago Next based on the success of 1871. Matter is the life science or biomedical one. It's the first of these new centers coming on board. Steve is heading up that effort. He's going to tell us about it. We have Propel, which is the business development arm of Illinois Biotechnology Organization. We've got ISTP in Skokie. I mean, the list goes on and on and on. We have the Jump Center, which John's going to tell us about. And we're almost in the Illinois Medical District, which is going through another rebirth. Lots of things are going to happen there. So there's a lot more going on. I could make up 50 slides for you. I just want to paint a picture of what's going on. So how does it all come together? That's what we're here to talk about today. So each of our guest panelists is going to give you roughly 5 minutes on what they're doing. We want this to be more of a discussion than a lecture today. I really wanted to set the stage. So thank you for having us all. I'm going to sit down. We'll just go down the hall. So down the line, Steve, why don't you tell us about yourself and about Matter?
We're going to stay informal. They're going to sit here.
Thanks. It is a really great time to be an entrepreneur in the healthcare space. And so I want to just talk for a couple minutes about that and about what we're doing in Chicago, and then hopefully get into some questions. If you think about being an entrepreneur today, the barriers to entry have come down dramatically, so it's easier to get into the game. If you think about in the healthcare space, there are policy changes that you're probably all familiar with that are pushing healthcare delivery systems to be more accountable. There are market pressures and consolidation that are pushing delivery systems to be more efficient. There is an availability of data now and the ability to collect it and analyze it that we've never had before. And so this is creating enormous opportunities for entrepreneurs to innovate and creating market opportunities for them to find receptive audiences for their products and their technologies. Now you think about what it means to be an entrepreneur in the healthcare space in Chicago. We have world-leading companies across the spectrum of healthcare. So you think pharmaceuticals, diagnostics, medical devices, pharmacy, health IT, hospital supply, kind of you name it in the world of healthcare, and we have literally world-leading companies right here in Chicago. We have some of the finest research institutions that are churning out really cutting-edge innovations and technologies. We have some highly innovative healthcare delivery systems. We have the American Medical Association based in downtown Chicago. The American Hospital Association is based here, and a number of the specialty medical societies are based here. We have the highest concentration of physicians per capita in the Chicago area, and we have conferences here. So I was at the AVIA conference, the big sort of medical device conference. We have those conferences coming through Chicago all the time, so there's a flow of ideas and talent coming through the city. And we have, for many of the reasons that Steve outlined with the different pieces, a growing and dynamic community of entrepreneurs who are building next generation businesses in the healthcare arena. What we have not had historically and don't have is a center of the community, is a place that really pulls all of those pieces and resources together that can help innovators form companies and help entrepreneurs build businesses. A place where, a physical place where there is mentoring and there's classes and there are connections with industry and health systems and universities and investors, and a place where it really all comes together. So if you're an entrepreneur, if you're Scott Vold out there trying to build a business in the health technology arena, someplace where you can go and you can immediately plug into a community and find the people and the resources that you need to really accelerate the growth of your company. So that is what we're building with Matter. It'll be a 25,000 square foot space in the Merchandise Mart. It's been sort of incubated by the mayor. We partnered early with Governor Quinn, and the state has provided $4 million for us to get off the ground. We're in the process of building partnerships with a number of companies who are supporting the launch, and we will be open early next year, and I will be delighted to take any questions you have once we get to that point in the program. Thank you.
Go down.
Okay, good. Thank you. I'm Eric Langshur. I'm the CEO of AVIA. And we have a very complementary, really, lens on what's going on in the innovation space in Chicago and nationally to Steve's and what Matter is doing. We look at it through the lens of health systems and providers. So when we started to think about this issue of innovation and some of the macro themes that we're facing, really as a healthcare system, as a country, we got pretty fired up about really the imperative to innovate. So I'll just share some core statistics with you that you're probably mostly familiar with. So as a country, our household income is $55,000 on average, and we're spending on average $17,000 of it on healthcare. And we're at the wall. We need to do more with less because we've run out of room just to increase rates on a fee-for-service basis. We're on the other side now of over $40 billion of economic stimulus to introduce EMRs. So really the industry has entered into the information age. But EMRs, which have been required, really aren't sufficient to sort of drive the transformation, the innovation that's necessary really to, again, to deliver better care and at really good, better value. But it's set the table. The industry now has entered the information age. And as a consequence now, we're seeing billions of dollars rotate into healthcare IT spending and innovation. So far in 2014, there's been about $2.8 billion in venture investment in healthcare IT. In all of last year, there was $2 billion. And all of the year before, there was $1.5 billion, and then just $1 billion the year before that. So massive, really massive sort of stimulus. And to Steve's point, it doesn't cost as much money today that it did 5 years ago even to start a technology company, because we can really do a lot more with less. So from a health systems perspective, this issue of managing technology is really it's a new the challenge of it has a new flavor. Whereas 10 years ago, 15 years ago, typically a CIO's budget was in the 3 to 5% of total health system spend. We can read statistics now where it's approaching 17%. So this issue now is no longer from a provider's lens, no longer just an issue of that resides with the CIO. It's a board issue, it's a CEO issue, it's a CFO issue, the entire C-suite is engaged. And then, while they're engaging, the world is increasing in complexity. And so hospitals need to parse through, all of these really formidable forces at work. So what we at AVIA elected to do was to get at the issue of helping companies accelerate, but to do it in a way where we organize a national group of health systems who are all facing very similar challenges. We call them contemporary provider challenges. And so the same sort of issues that Sinai faces. And I would actually venture to say that Sinai's, the imperative for Sinai is probably it's more challenging here given the thinly resourced nature of the health system here. And in fact, in that regard, I've always shared this with Karen over the years, but I think of Sinai Health System as really the most important institution delivering care in Chicagoland, and by far. So we started with this vision of let's help health systems really parse through just the noise of innovation that's out there. So I think Matter is just doing such a fantastic job as for example, of stimulating real innovation, companies that are going to have real impact. But then how do people who are coming to work every day to run a health system and to deliver care in a hospital setting parse through all that activity? So at AVIA, we were inspired by this idea of using scale and really linking systems together around the spirit of collaboration and working together. And I'm actually delighted to say that Sinai was one of our very first members in the network, who really got the joke that this is important. There's important work to be done, and if we collaborate and use a partner to help us do it, we can probably do it a lot more cost effectively if we did this entirely on our own and find better solutions and get to better results and have more impact on care. So that was early last year, And today we have over 100 hospitals in the system, in our network. So, Sinai is among very good company, including the other, less well-known Sinai in LA. Cedars-Sinai is a member, the Mayo Clinic is a member, OSF is a member. We've got some really large systems. Providence Health and Services, Sutter, some really wonderful partners of leading institutions who understand that if we work together, we can actually accomplish more because we can de-risk innovation, we can group purchase and get much more value, and then importantly, innovation only matters when it's implemented, and we can have more impact. So we work with University Health System Consortium, the group that aggregates 120 academic medical centers in the country, Deloitte, the AHA, large-scale institutions who really want to get at this idea of having impact around innovation. And essentially what we do is we start with a problem. We start with a challenge that a hospital that you all are facing into. And so the patient experience, patient engagement. We know we're now living in a digital world, for example, and we're all carrying around a phone. And certainly Sinai's patient population, are wired with phones in their pocket. So and there are now literally hundreds and hundreds of early stage companies that are reporting to have really great solutions that will move the needle for providers. So how can any one hospital or health system find the right solution that's going to help move the needle with the way that they deliver care, and then purchase it and help implement it in a scalable way? And that's what we do on behalf of our members. So I'll pause there, and I think a great example of an innovation in the referral management space is Fibroblast with Scott.
Thank you. That's a perfect segue. Good afternoon. I'm Scott Vold. I'm the CEO and co-founder of a company here in Chicago called Fibroblast. We automate the patient referral process to ensure that no patient falls through a crack in the healthcare system and ensure that providers get the care, the revenue they deserve. And to tell you more about what we do, maybe I should tell you how we got our start, because I think that informs the company mission. So at the time, I was practicing law. I'm an outsider to healthcare. And I was having breakfast with a good friend of mine who's now my co-founder as a physician here in town, an independent physician. And he came to me and said, I have this problem. I'm really concerned about something. And it's on my mind. And I want to talk to you. But this was like 6 a.m. This was before he started scoping anyone for the day. And so for him to be so upset this early in the morning signaled to me this is a big challenge for him. And he said, here's what happened. Patient went into a colleague of mine's office, a primary care doctor. The physical the patient had put off for way too long. And the primary care doctor did the full battery of tests. The urine test came back, and the primary care doctor saw something that was abnormal. And said to the patient, look, there's something here, it's not quite right, I'm a little concerned about it. There's this thing called a hematuria. It's concerning enough to me that I think you need to see a urologist. So the primary care doctor did what primary care doctors do across the country, and what the state of the art is in patient referrals. He took out a piece of paper, right? He wrote the name and number of a urologist on it, tore it off, handed it to the patient, and said, call this guy. Make sure you get in, see him, and then let me know what happens. The patient took the piece of paper, put it in his pocket, went out of the office, and went on about his day. Primary care doctor was concerned, called the patient a few times to try to follow up, see what happened, couldn't get through, left a few voicemails, what have you. 18 months later, the patient died of bladder cancer. Right? Never followed up with that urologist. In fact, failed referral appointments happen more than 51 million times a year. So Andrew, my co-founder, said, I'm really concerned about this. Not only is this a nightmare for the patient and the patient's family, this is also a nightmare for the primary care doctor. It's a terrible outcome for the urologist, the health system. And he said, I'm in the middle of this referral chain. I'm a gastro. I get patients referred to me all the time. I don't know who's not showing up in my office that ought to be, but I do know that every week that goes by, I'm scoping people in their mid-60s that should have seen me in their 50s, and I'm finding cancer. And then, when I find cancer or something else that's very concerning, and I refer them to an oncologist or a GI surgeon, they're not showing up. I know for a fact not everyone is making it to where they ought to go, because I'm calling the surgeons, I'm calling the oncologist, I'm asking if my patient followed up, and they have no idea what I'm talking about. There's got to be a better way. And so we got to thinking, Google can track every web search you've ever run, and Fitbit can track every step you take throughout the day, but there's nothing really that tracks arguably the most important step you could possibly take, which is in that consulting physician's office for your referral visit. So we set out to solve this problem. How do you close the loops in the referral process? How do you automate what is a broken, often manual, paper-based process in a way that's simple, easy, and convenient for the physicians, that adds value for patients, makes it easy and convenient for them to show up, and also adds value to health systems, right? Especially as we think about value-based care and accountable care. How do you ensure that patients stay within a given network? You drive preventative services to manage population health. So I left the law. Andrew devoted a lot of time from his practice at the company. We built a thriving startup here in Chicago, first going through Accelerate Labs, which is now Techstar Chicago. Hopefully we'll be in Matter when it opens. And we're out there talking to innovative health systems like Sinai now. Thanks for your time.
Thanks, Scott.
I'm more of a visual person, so I'll go up to the podium. I'm exposing the fact that I could have helped Steve, but chose not to. So I'm really pleased to be here with you. I will talk very quickly. My name is John Vozenilek. I'm the Chief Medical Officer of the JUMP Simulation Program. It is more formally known as the JUMP Training Simulation and Education Center. It's located in Peoria. For those of you who are not familiar with Peoria, it is a minor suburb of Chicago. At least that's what I told my wife when I was recruited from Northwestern. I led Northwestern simulation program there. Was instrumental in increasing its exposure to entrepreneurship and taking that show on the road. So I'll tell you a little bit about what we're up to. I think it's quite traditional to think about simulation centers as centers for education. We do a lot of team training. This will be a familiar concept in healthcare. There's a healthcare team resuscitating a newborn child who is actually a simulator. This is a simulator device. This is the standard form of academic simulation in healthcare today. Lots of team training, lots of performance of skills, and checkoffs of competencies. This is another type of team. This is the team that I'm also on and training. This is the U of I biomedical engineering team that won the Coulter competition, which is the national competition for biomedical engineering, for the creation of a new device with high potential in the world market. It's a wonderful team. You'll notice on this team there are quite a few women. Professor Amos, who's sitting next to the bulky guy, let's see, on your right, is a professor at U of I UC in biomedical engineering. And then the rest of the team are students. There are 5 women and 1 male student. In biomedical engineering, it is a non-traditional sort of proportion. In mechanical and other fields, disciplines of engineering, the proportion is more like 70-30 or 80-20, male dominated. In biomedical engineering, 50-50 split. It's remarkable, and I'll talk a little bit more about that later. This is my project, this is my building. It is a 6-story building. It has 160,000 square feet, and it is dedicated to the principle of education, research, and innovation. This is located right next to St. Francis Medical Center. It's connected to St. Francis Medical Center, which is a tertiary care hospital serving central Illinois. This is a picture. JUMP is the building on your left, and the hospital is on the right. It stretches up the bluff. This is what we built. Our first premise was that education could be enhanced by creating very, very high fidelity spaces. This is a picture of our simulation center. It looks just like our hospital. You'll notice that there's cameras and some one-way glass. We expanded the concept beyond simple patient rooms and built a whole floor with an intensive care unit, nurses stations, med stations, Pyxis, blanket warmer, et cetera, et cetera, et cetera. It was a little bit of a crazy idea to do this all this way, but we had a purpose in mind. We included a little house. There's a little house in the background there. My wife's grandmother built the curtains for the house. She's 97. She says hello. You'll notice that there's an ambulance inside my building. That is because we do have considerable number of pre-hospital personnel who need to understand training. The house has been used for a variety of things, not only for EMS, it's also been used for large companies like Care Innovations, Intel GE's joint venture that does home health care devices. And so we're actually running studies right now inside our little home. We have the full-scale OR presentation complete with monitoring stations. We use a variety of plastic people. This is my little plastic family. Here's one of them. This is a neonatal simulator. We do full-scale operative simulations to prevent issues in the OR and to increase resiliency. We do a variety of hands-on practical training for surgeons and others. But our scale is full scale, starting with patients who come in from outpatient, full incorporation of teams and technologies that are being used to administer care through the various disciplines of medicine and the paraprofessionals that serve our patients. The use of the electronic medical record and other technologies is embedded inside the system, and we're constantly looking for ways to enhance human communication skills surrounding these technologies, which is a focus area that I'll come to next as well. Certainly that could be between staff and also between providers and patients. This is what we're looking for. This is a bicycle that has been modified in a couple of different ways. This is the Copenhagen wheel. This traditional bicycle, as you know it, has now been modified to store energy in this rear wheel, and the energy is stored there as someone pedals. And big fat guys like myself, when they need a little boost to get up the hill, they can push a little button and get a little up the hill, right? Which is great. It also has on the handlebars a little spot for your iPhone or other device. It can tell you about smog conditions, it can tell you about the traffic conditions. This is really a difference in the way bicycles are addressed. This is a futuristic bicycle, a true innovation. And that's what we're looking for in our simulation center. So we're not just using this for education, we're actually using this to combine engineers with clinicians to solve problems in healthcare. This is our image that represents that thought bubble. And we have incorporated not just students, although we do enjoy very much the biomedical engineering students and other disciplines. We actually hire biomedical engineers that work in our simulation center to design new training devices, because there's a variety of training that is yet to be reduced into some kind of practical form. So our engineers build these training devices in ultrasound and other topics. Here's the Brady Bunch of the biomedical engineers. This is the Coulter project that I referred to earlier, to organize the mishmash of lines and wires that occur in all kinds of intensive care unit settings. We use technologies to test these types of solutions. We use the full-scale simulation center to bring those biomedical engineers into context. We use the facilities of the hospital to give them a sense of what really goes on in the real world, and then we test it in the simulation laboratory. We've had a major advance in three-dimensional printing. 3D printing is everywhere. It's a thing that is incredibly fast-paced and moving. 3D printers are ubiquitous now. However, using the 3D printer to reduce operative time for children with congenital heart disease is actually an innovation. We take the MRI images and CAT scans, reduce them into three-dimensional form, and then print them so that the surgeons can do operative planning in advance of surgery. This has dramatically reduced operative time and prevented some children who would have been damaged by bypass from going on to bypass in the real world. The NIH has caught wind of this particular set of projects and has given us our own collection. So there is on the NIH website today a collection of human hearts that are children who have been addressed through this technique. We're doing projects in radiation oncology to improve the safety and quality, not just of the teamwork and access to patients to this technology, but also the safety of that radiation beam. We're advancing through teamwork the care of patients with septic shock. We are building new games to teach nurses and doctors at the point of care. We're advancing our understanding of all of the technologies that some of our panelists have referred to expand these technologies and make them more useful for diagnosis. And we're looking at conditions which affect clinicians. So this is a worn sensor device that gives a warning when a clinician is fatigued, perhaps in the OR. So this is an OSHA project for us. I will tell you one last thing about what we're doing in SIM, which I feel is very inspiring. And I referred to the fact that women are very present in biomedical engineering today. We do quite a bit of science, technology, education, engineering, and math training out of JUMP. We think that JUMP is a unique opportunity for people, particularly young ladies, to understand different types of careers in medicine. And some young ladies may choose to go on into biomedical engineering or other engineering careers through this juxtaposition. You can see the young lady in the foreground, right in the middle. She's not quite sure if she likes what she's seeing, but she may have an opportunity to explore it further through the Simulation Center. I referred to the building. The first 2 floors occupy about 70,000 square feet of educational space. The second 2 floors are designed as an extension of the classroom of the UIUC College of Engineering. We're combining our data analytics teams, our performance improvement teams, telehealth, and other teams to advance their understanding of what's in the electronic medical records so that we can design new healthcare technologies. We have a $62.5 million endowment which funds this work. And all of this work goes to serve the mission of OSF Healthcare, which is not dissimilar than Sinai's mission. We don't refuse any patient. The only difference is my board of directors. When I look at them, every other person is a sister in habit, so go Franciscans. Our vision for the next 2 floors of this building is an innovation center. We do think there's room for entrepreneurship, for accelerators and other technologies. And I'd be happy to discuss that with you further during the roundtable. So thank you for having me.
Thanks, John. Thanks.
Thanks, everyone. So I have a question for each person just to get this thing going, but we want to make sure the audience participates. I just want to follow up. I have visited the JUMP Center. And it's unbelievable. I know John would welcome you if any of you are in the area or want to go. It's phenomenal. We've also, John and I started interacting about a year ago. I introduced him to Steve and Matter, and we're delighted that, I don't know if it's final, but we certainly anticipate that JUMP will have a presence at Matter and play a role in this environment in Chicago. So what I want to do, just to start, I'm going to ask each person a question. If you don't like the question, you can answer something else. But I want to try and bring Sinai into the equation. So for Matter, Steve, by the way, how many people here knew about Matter before today? Okay, so you're hearing the story for the first time. So pay attention. You're going to see more and more visibility about Matter. Steve is staging this for the planned opening early next year. Tell me a bit, expand on how hospitals will fit in. So for Sinai, you talked a lot about the entrepreneurs and all the other pieces. Tell us a little more about places like Sinai in particular might benefit and what role they may play in there.
Sure. So if you think about what who will be in Matter and who most of our members are, there are startup companies who are creating innovative products for the healthcare space. And I'm not sure I touched on this before, but we're working with software companies, diagnostics, device companies, and pharmaceutical companies. One of the, so there are several ways that we could work with Sinai. I'll give you a couple that pop into my head. But one of the things that entrepreneurs are challenged with are access to health systems and trying to, if I'm a 2-person company and I'm trying to, I feel like I've got a breakthrough and I'm trying to figure out how the product is actually going to work, I actually need to talk to people who are practicing medicine and involved in the delivery of healthcare. And so to the extent that there are, we are looking for partners for health systems that we can help plug our companies and our member companies into so that they can get feedback on the products from the earliest stages so that they design products that actually fill a need in the market as opposed to what sometimes happens, which is they design products that don't fill a need in the market, and then that doesn't work very well from the entrepreneurial point of view. That is, why don't I just stop there? That's the first way that comes to mind. I think there are probably several other ways, but I'll stop there and let the discussion continue.
Great, thanks. That's what I wanted you to say. Eric, I would love you, if you can, talk about an example, either at Sinai or one of the other places. So you told us how you're basically matching up the innovators with the users, if you will. Give us an example here, if you can, if not, something else.
Sure. We're in the middle of working what will hopefully turn out to be a really nice program for Sinai. There's an early stage company that's very well funded in Chicagoland area that is looking to aggregate services. So picture, off-hour MRIs and buy them and then turn around and sell them to employers directly. So, we're working to really bundle, bring Sinai into the forefront of developing a service offering that can take, any potential additional capacity or excess capacity, be it during the day or off hours, bundle it at a competitive rate, really create a user experience that's unique, sell it directly to employers at commercial rates, and then really drive utilization and drive revenue, incremental revenue to the institution. So that's an example.
Great. And that's something that it's unlikely Sinai would have been able to do that on their own, right? Okay, terrific. Scott, can you talk through, as you are out introducing your product, selling really, are you talking to physicians, are you talking to hospitals, are you talking to physician practice groups? How would you introduce your product here? You can do your sales pitch.
Sure. Well, so Sinai is slightly of a different opportunity than we normally approach, but to answer your question, we can typically talk to senior leadership, CEO, COO, SVP of strategy or business development, and also senior clinical leadership. The idea there being, we really are a tool to not only help drive better care delivery, but also help increase top-line revenue. And so I think there's a sweet spot here that we hit, which is you're delivering better care, but you're also doing well or doing good, or doing good or you're doing well, whatever the phrase is. And so, there's tremendous opportunity with employed physician groups, with particular departments like GI. So one idea of Sinai, for instance, is really promoting colon cancer health and colon cancer awareness. Not only is Andrew GI, so we think about GI issues all the time, but for a health system like Sinai that has a large African American community or population that has issues with colon cancer, I think there's a lot of benefit we can do there by linking patients together, making sure no one falls through the cracks, and by promoting preventive screening services.
Thanks. And John, that was a great overview. Again, having been there, it's impressive every time I see it. So you told us how OSF is using it. Are you hoping to bring other health systems like Sinai into use JUMP, and if so, how might that occur?
So it's actually really interesting to come into OSF healthcare system with this type of entity. At first, especially when dealing with the university, there were a lot of matters relating to intellectual property and concerns about ownership of ideas. And we actually had to work very hard to solve some of those problems, and we've solved the vast majority of them. But the sisters reminded me, and they brought me into the office and the whole thing. There was no ruler. Sorry, sister. There was no ruler, but I was reminded, Dr. Vozenilek, please remember that we're in this for all the patients. And anything that we discover here, whether it's education and research or in innovation, the purpose is to disseminate it worldwide. That's our mission. And so, yes, indeed, there's plenty of room for our healthcare community to come and to work with us to solve these important problems in healthcare. I do believe there are very significant challenges and very significant technologies that are just waiting under the surface.
Great, thanks. Let me open it up to the audience, and if not, I know I can keep picking on the panel here. So I hope some of you have questions. But you'd all rather listen? Yes.
This would really be for Scott, I think. One of the issues that we see in the outpatient clinical environment is a very big issue for us, and we talk about it and tap it from many angles, and I think it's improved, is the no-show phenomenon that you talk about. it's a very big issue when you look at each clinic. And I'm just wondering, not really being familiar with your technology, how, in a kind of a concrete way, it might impact on that. When we have patients whose phone numbers change and they're relatively unstable, they're lower income people sometimes, and they just don't show. And, big issue, 50% no-shows.
Sure. So did everyone hear the question? How do we tackle the problem of no-shows in a community where phone numbers might change and there's a history of non-compliance among the patients? Okay, so I'll say this. We're a technology company, right? So fundamentally, there's a technological component, and we need a patient to adopt technology in some way. Now, fortunately, 85% of adult Americans have cell phones, and 58% have smartphones, and all of those are capable of receiving text messaging. So one of the ways we've tackled this technology gap, this technology challenge, is to make use of SMS messaging, text messaging, if you will. And so we've seen patient no-show rates decrease, right? I'd say patient attendance rates increase by more than 30% just by using simple automated text messaging to confirm appointments, to remind patients of appointments, and provide them easy access to rescheduling, from their phone. And then if they don't show up, we actually automate the follow-up or worry list, so we can ping a patient with a message that says, hey, look, you missed your appointment, it's really important that you go. Click on this link to reschedule, which then calls in the physician office. So assuming Sinai patients do have phones and can receive text messages, that's the easiest channel to tackle, if you will. Maybe that was bad now. Attack is probably the wrong word, but you get what I'm saying. Anything else?
Any other questions from the audience? Okay, this question, yes, sir.
So this is to anybody in the group, but maybe more to John, but anybody to answer. Healthcare is moving in a different direction. Hospitals are becoming dinosaurs, and healthcare can be provided much more in an outpatient, in other settings, varying levels of outpatient or intensity, varying levels of intensity in the outpatient setting. John, what you showed is beautiful. How are you looking at that, which is a different set of skills and is somewhat low tech? And to all of you, what can we do in that setting, which is going to be much more important over the next 5 to 10 years?
So the question was, with the transformation of healthcare to a more outpatient stance, how do we take care of that challenge and address it with the various modes at this table? So for myself, our endowment, which brings in the powerhouse University of Illinois Urbana-Champaign College of Engineering, all of the technologies that will be funded are going to be technologies that address community health problems. And so you can imagine with a wealth of technology coming out of the U of I, all of the opportunity there. But we focused on this because of this challenge, because of this transformation to more population health management and outpatient stance. And so the technologies that will be funded through that endowment will be advanced sensor technologies that help us give information about patients who are in their home, imaging technologies, data security technologies, data transfer technologies, and a variety of instruments that will help us to address patient care more so in the outpatient zone and in the home. It's one of the reasons why we built a home within the simulation center. Because although there is an existing pressing need for advanced training in inpatient, our vision is this is going to become an outpatient-centric game.
Yes.
If I may, we happen to be very excited about the idea of healthcare moving to the retail setting. So flash forward 5 years from now, you go to Walgreens for mouthwash and Band-Aids and a candy bar, and you get your flu shot and a blood test or a checkup and whatever. And so we see that as an exciting opportunity because you have mid-level providers providing quick and dirty type of primary care and then we see ourselves as the piping to get a patient from point A to point B to point C. Perhaps something is spotted in a retail setting that needs to escalation to a primary care physician, which then has to be escalated to specialty care or tertiary care. And so we think we are the way for a patient to move through that system. And I really do think that's where the puck is headed, if you will.
Yes, sir.
I was intrigued watching the coverage of the Ebola situation in Dallas, that the first thing blamed was the innovation. That it was the electronic health record that prevented the nurse from effectively communicating with the physician. It wasn't that the doctor didn't take a travel history, which apparently didn't, all those kind of things. But either Epic or Cerner got a little slack from those nice people that were talking in Dallas. What do you do when an innovation becomes perceived of as adverse rather than positive?
Did everybody hear the question? Yeah. And I didn't read that, so
That was they went the next day. They said, we didn't need to say that, but when you say something the first time, you probably need that.
Okay, so that's a broader question, but I guess it's the role of technology. Are we helping or are we getting in the way?
When it's perceived as adverse, because if you don't know that, I mean, someone could say they didn't know how to use it right, and the nurse did her job, the doctor didn't do this or whatever.
So John, let's start with you, because you're probably the only one of us here actually using the EHR.
So it is, just imagine the customary pathway for the purchase of a new technology inside a healthcare system. So that technology firm has a wonderful pitch, they have a wonderful presentation, they convince a few key leaders, and then the sale is made. No, it's fairly traditional. Perhaps there'll be some proof of concept testing in a focus area, right? Well, imagine if you added one additional step to this pathway and you had an asset like this that could actually intake the technology and do a full-scale test of the technology and help you to understand not just the pitfalls of a particular technology, but the training burden required when the new technology was introduced into healthcare. So I'm answering your question indirectly, but I'm pointing out that yes, there are techniques that are coming on board that allow us to do a better job of anticipating some of the barriers, and some of the non-traditional paths for healthcare innovation are going to allow us to be safer.
Let me broaden that. Go ahead.
I was just going to add that it's a great question, and there's a whole new set of risks that are surfacing, and we've got to come up with new processes and new ways of managing those risks.
So I want to expand actually on your question about hospitals becoming dinosaurs. I don't know if the word is dinosaurs, but they're changing. So part of the whole ACA is this focus on improving outcomes and reducing costs. And any new innovation is going to cost money. And so Eric and Scott, you're dealing with that more than the rest of us right now. How are you helping hospitals assess, and how are you selling that this is a good ROI for people?
Well, we're in a mode where most balance sheets are, diminishing in their strength, and we're kind of staring at this phenomenon of a weaker P&L for most health systems, and there's an imperative to act, but there's also an imperative not to make a mistake. So the days are gone where we can say, oh, we're going to try this and let's hope it works. So we've got to be very judicious with our choices and our decisions. And then the organizational, because these are typically really complex systems, the organizational lift required to implement, to test, to run it through a simulation, to make sure that these technologies will interface with legacy systems, that people and technology are working together is very complicated. And so it requires planning, it requires process, it requires a lot of effort. So we've got to be, we've just got to be very, very precise with those choices that we make and the bets that we make.
And Scott, how do you sell that the expense of acquiring your product is worth it?
Sure. So we're lucky that we happen to be a fraction of the cost of an EMR system. So there's not much sticker shock. But what we're seeing, especially when we're talking to accountable care organizations, our patient leakage rates in excess of 50%. Right? That's literally patients leaving one facility, one health system, and going to higher cost competitors. And so there's a bit of a burning platform. We'll go to the executive director or CEO of an ACO that lost $80 million last year, and they need some better way to manage patient referrals and eliminate patient leakage. And we're finding very receptive audiences, at least conceptually, about referral management. Problems we run into are more institutional problems on how to buy technology, right? The decisions being made by the collective. But that's another story. So we're seeing ready-made audiences based on high patient leakage rates and this burning platform. And I think you can do the math pretty quickly and say, okay, if we reduce our patient leakage rate by even 15% next year, it pays for Fibroblast, many, many times over. And ultimately, we're a tool that pays for itself and can help drive revenue in the right direction. So we have a very clear, hard ROI.
You have accumulated enough experience in your short history to demonstrate that already?
Absolutely, yeah. So thanks. If I can tell you about a couple of experiences. Not to get too salesy, but so let me give you, I think, maybe one very appropriate example. So there's a community clinic on the northwest side of Chicago. You can think, it's not an FQHC, but you can think of a patient population very similar to an FQHC. A lot of patients with chronic conditions haven't had a good history of being compliant patients. And the clinic is also very resource constrained. So prior to Fibroblast, they had a 73% patient leakage rate. They could not get a patient to walk down the hall to go see the nephrologist, the cardiologist, or to come back the following week to go see some other type of GI, for instance, right? And patients were either crashing into the emergency rooms of hospitals in the area or simply doing nothing. So we started talking to them and they said, look, we have this existential threat. We have 73% patient leakage rate. There's got to be something done. And so we deployed Fibroblast in the organization, and in a very short amount of time, frankly under 90 days, we took their leakage rate from 73% to 18%. It's a 75% reduction in patient leakage. 18% for most organizations is still pretty high. For this organization, I think it was a lifesaver. So our technology works. It's been validated in the market. It's simple, it's easy, it's lightweight to use, and the ROI is fairly clear.
And Steve, I want to come back to Matter and ask you to comment. So we said we hope to have Jump there. You may want to talk about the makerspace and the MA project and how Matter may help with evaluating behavior and uses.
Sure. And as I want to touch, I was thinking just on the last question about the sort of economics, and if you think about what an innovation in healthcare technology used to mean, it used to mean a device or a new molecule, and depending on what it was and where it sat in the flow, there could be significant capital outlays required of a health system in order to implement the new technology, and so then that creates barriers for potentially a system like Sinai as compared to North Shore or someplace else. It's really exciting to me, and you heard I think Eric talk a little bit about it as well, and that now an innovation in healthcare technology can mean those things, but it can also mean a piece of software or an algorithm or some type of analytics, and some of those things have a very low outlay required to implement them and can lead very quickly to a higher ROI, either by driving up the top line or by driving down costs. And so that's exciting I would think for systems across the board, that there are opportunities to look at technologies and implement them that can directly affect outcomes and patient care in a cost-effective way. That doesn't answer your question at all, but wanted to.
Well, I was trying to link it, and in the broad sense, the question is how do we evaluate new technology? So I think simulation is one, and physician behavior, and sort of if it's not too early to talk about some of the ideas related to the AMA or not.
Sure, and you did tell me, by the way, that I could answer whatever question I wanted. It didn't have to be a question asked.
Like my kids.
So we're working with a couple of groups on some innovative spaces within Matter. So you think about what Matter will physically be. It will be an environment for entrepreneurs to work. There will be shared desks. There will be some private offices. We'll have a large event space. We'll have a classroom, a lot of conference rooms, places to go make phone calls, places for people to both meet and do work of building their businesses. In addition to that, from a healthcare innovation point of view, there are a couple of sort of unique environments. So one is the ability to test products in an environment that is, that allows you to get some feel for what the interaction is going to be between the caregiver and the patient. And one is, or if you have a new product, to be able to test it in an environment that looks something like a real-world healthcare delivery environment, as opposed to a conference room or something that has no resemblance to the world of healthcare. And we are hoping to put a couple of those spaces inside of Matter, and are in discussions with the Jump Center and another group about collaborating on that type of environment. Steve also referenced something that we're calling the Shop, which is a sort of a lab for medical device entrepreneurs. One of the things that's exciting about innovating in the medical device space is, due to 3D printing and the advances of some other technologies, the cost of developing a prototype is coming way down, and the ability to print prototypes and to assemble prototypes in a relatively low-tech environment allows for medical device entrepreneurs to iterate their products more rapidly. And so we're working on a space within Matter that will also be for medical device entrepreneurs that we're quite excited about.
You got a question?
Yes. I think someone had asked a question earlier about the impact of innovation. My question is, as you're working with companies or in healthcare, the big issue is the readiness for also addressing processes and systems, because technology will not fix that. So can you speak a little bit about that? Because I think that's where the hardest.
What's the question? How does health technology innovation affect processes and systems?
Change, right?
Change.
Because it does not, processes and systems flawed, does not, technology doesn't really address that. So how do you have to have that balance? So a lot of your examples, especially at the Jump Center, was about addressing the processes and systems along with the technology and innovation.
Anyone want to tackle that, or you want her to be more specific? An example.
I think that's the answer, Donna, right? You've got to do both. These are complex technologies, and these are human systems that are also complex. And I think it's one of the reasons it takes so long to introduce these innovations, is because these are tried, true, and well-proven processes that we're loath to just change willy-nilly.
Just add another dimension to your question, which is, if you're an entrepreneur and you're trying to develop an innovation or develop a technology for use in a health system, one of the challenges is that the systems themselves are highly complex organizations, and it can be difficult to, on a number of fronts. One, it can be difficult to just figure out who to talk to and who the decision makers are and how the decision-making processes happen. But also, there needs to be a realistic, and this is one of the ways where Sinai, I think, could help in interacting early with entrepreneurs. There needs to be a realistic discussion about whether the system or the innovation or the technology that is being developed will fit within the systems and processes that exist, because you can push them a little bit and you can push the envelope in one direction or another, but a new technology in and of itself is not going to reinvent a whole process and a whole way of doing business. And so there needs to be a sensitivity and an open lines of communication between the practitioners of healthcare and the innovators and entrepreneurs who are building products that they want to have influence the healthcare system.
Yes.
Building off that question and a few other comments, sitting here at Mount Sinai and also practicing at a community health center just a few blocks away, I worry that some of these technologies, although great in theory, may actually deepen some healthcare disparities through offering better technology, better solutions for those who can access care at places that can afford the technology or afford to implement them. So I appreciate some of the comments that some of you made in terms of how underserved populations can benefit from these technologies. But at my health center, I think we like to think of ourselves as innovators, but as you were saying, I think we don't necessarily innovate by buying an expensive technology or bringing in some of the new technologies you're talking about, but rather by changing the way that we work with each other and innovating in that way. However, as you can imagine, that's in similar ways that implementing new technology can be expensive. That's expensive because it leads to, as we're trying out new things, decreased productivity on the part of providers. So I wonder if there's any space or if there are people out there thinking about, for instance, the Jump Center, ways for community health centers to get funding to do a training there and to think about how they can work together better to address some of these solutions in the clinical setting. Or, for instance, if Matter has thought about with the work with the mayor and the funding that we're getting from the state, to think about how to incorporate some space there for people at community health centers to talk with folks that are working on technological solutions, to think about how we can, physicians can work with MAs better in the setting of community health centers to address some of these inefficiencies.
Great question. Did everyone hear his question?
So how, let me give it a shot summarizing. So how can these whiz-bang technologies still be present but ensure that healthcare disparities are addressed? And I love this line of questioning. I appreciate these two questions in particular. When I think about this subject matter, I think about the use of telehealth. I think about the idea of introducing a technology like telehealth into the healthcare space. I'm a clinician, and what is happening in the clinical moment is that the provider and the patient are having a conversation. And all of this whiz-bang technology tends to, on surface, increase the separation between the patient and the provider. And it's a concern of mine, and it's a concern of Jump's. And so we love these things. We love the apps. We love the pieces of gizmo that make things go. But what's really key is culture and human behavior. And if we keep our focus on compassionate competence across the board and providing compassionate healthcare at a competent level, I think that we can bridge the gaps. In particular for healthcare technology that's delivered through the screen as a program that we're rolling now. We're actually working with mid-level providers and other providers to ensure that they're displaying these compassionate human behaviors despite the use of the technology, to bring that rapport and concern through the screen. I am guilty of it today. I was tweeting while we were talking. We get distracted by our technologies. That can never happen in the moment where a patient and a provider are having a meaningful conversation about a difficult diagnosis or something else that is not well understood. Now, I invite you, let me just say this to you directly, Doctor, I invite you to come and join us and take a look at what we're doing, and I invite you to propose some solutions in healthcare disparities. In Peoria, we have very similar conditions to the city of Chicago, but in a microcosm. So thank you for the question.
Good answer. Steve, he asked you also?
Yeah, I don't have a great answer for you yet. We're in the process of putting Matter together. I've had a number of discussions with the city, with the Department of Public Health, and they're very interested in population health, right? And so that crosses sort of all of the types of delivery and following patients into the neighborhoods,
And we've had a number of discussions about things that we could do to improve population health generally across the city. And I'm hopeful that some of those things will pan out, and we'll be running specific programs and doing specific things in that area. We're still sort of sorting that out as we put the space together.
Actually, I have a comment. Steve and I have been involved in a couple of efforts to try and get national funding from national government organizations, the best in the reach, using matter as sort of the centerpiece to bring everybody together, so that we can apply to whether it's the United States government, NIH, whoever is providing funds, and yours is a great topic, to show that all the players are coming together. And so I think going forward, that's an opportunity for Matter in a way to distinguish itself maybe differently than the traditional incubator role, just building businesses, right? There was a question in the back. Somebody had their hand up. Yes.
This is an AVIA question. You talked about the increasing amount of money going to EMR, topping $2 billion this year. And so there's a lot of money made on that. But where is either the innovation or the federal mandate to make those EMRs talk to each other? Or to have those companies participate in the innovation so that either smaller physician groups or less well-to-do hospital systems can patch into that? Because you can get people to their appointments, but if we don't know what's happened at other appointments, that's not so great. And we can, check their blood sugars instantaneously, but if no one's aware of what that is, then we can't care for them. So it seems like, not the innovation, but the invention follows the money, but there's no sort of moral mandate for slowing it down.
Yeah, it's such a great question. So the issue of interoperability and data, the flow of information is a really big one, and we're not there yet, and we're still very, very siloed. But I think the good news is, with all the money that's flowing in, so you think about Scott's description of, he is the pipe. So Scott is, Fibroblast is a great example of how the free market is trying to link these different systems together. So Scott's platform is just a big, communication system that takes data in this format and reformats it to speak with another database. And I think we're starting to see so much activity, in many domains to get at this interoperability issue, because it's just so critical that you get the right information to the right provider at the right time in the right way to help the patient. So we're not where we need to be, but I think the optimistic side here, and the optimistic message is where the table is set and activity is started. And I like to believe that X years from now, maybe it's a decade, maybe longer, but we'll be having a very different conversation about how we treat information. We can go at any country in the world to get off an airplane and take our bank card and stick it in a machine and get local currency. So I'd like to think that day is coming in healthcare. And I would just come back a question too, because it was such an important question about the underserved and technology and people and process. And I'd point you in the direction of the California Healthcare Foundation, who's doing really fantastic work. So this is $1 billion+ foundation that was set up years ago when the Blues went private in California into WellPoint. And they have a mandate to really study that question. They're doing terrific work, and Wake Up is a collection of really smart people waking up every day to tackle those questions.
So I think we have time for 2 more questions. You've been very patient, so.
Okay.
We'll
I have a question really related to big data. I'm an anesthesiologist by training, so I love gadgets, innovation. There's a ton of companies that are coming up with either connectivities or blood glucose levels at home, weights, if somebody's opened their pill box or not, just tons of data that we get connectivity. And it's not just when they're in the hospital now, it's 24/7. So my question is really related to the management of that data from the physician's standpoint and the health system. Because if I'm getting aware of a patient that's got a critical glucose at 3 in the morning, like where that piece of it is to manage that and escalate it and discern what's need to be acted on and what doesn't. And so just your comments on how to handle all this big data.
So I'm going to start because I've been involved in lots of efforts looking at that. So the concept for everybody is different terms: mobile health, telehealth, Internet of Things, big data. Here's my little spin on that. The government's put a lot of money out there for electronic medical records. There are all sorts of incentives and penalties for improvement in outcomes or lack of improvements and reduction in costs. Because we've heard everybody say how inexpensive it's become to use technology to start a new business. Everybody and his brother is measuring something and saying, I can send this out and store it on the cloud, and everybody has everything available all the time. Sounds great. I'm data driven. I think I can't answer your question, but I think there will be some winners, and it's those that can show a benefit, defined in my mind as improving outcomes and reducing costs. So if you can show, people tend to use congestive heart failure as the biggest model. So I assume it's here, as everybody knows, your highest readmission will be for patients who are admitted for congestive heart failure that discharge, and they just started to publish how many hospitals are being penalized for 30-day readmissions that are too high. So I can give you 100 or more applications trying to monitor people in different ways to reduce readmission for decompensated congestive heart failure. So far, I haven't seen any that really can demonstrate that they can do that. They can keep the patient out of the hospital so the patient is healthier and you save costs. That's how I think we're going to pick the winners on that. But I'll let everybody else answer.
I think it's a great question. I think the reality is we're in a chaotic period of time, that there are huge advances in the ability to collect and store and analyze data, and that's coming at you and coming at everybody else from 17 different directions. And I think it's going to be a little chaotic for a little while. It's probably going to get worse before it gets better. And eventually there will be some meta platforms that start to aggregate it all and create a more rational way of processing the data. But my guess would be we're going to be in this situation for a bit longer.
Yes, last question.
Okay, I was just wondering, where does Chicago benchmark in terms of everything you talked about? You could look around the country, talk about healthcare, innovation, incubators, startups. Where do we benchmark to other cities? And then just give an extra plug to, with the great history of civic engagement of this city, if we were not only able to do business startups, but also make a real change in outcomes and reducing health disparities with what you're doing, that sounds like it would be so different and an exciting component to add. But just wondering.
So the last question, nice wrap up, is where does Chicago stand in relation, if we're trying to benchmark it to other areas of the country and all aspects? It's a great topic for you to start with, and maybe everybody can weigh in.
So Chicago has, if you look at sort of big companies and research institutions and big pieces of a healthcare ecosystem, we have sort of a world-leading collection of assets or resources. If you look specifically at measures of entrepreneurship and innovation, we lag the coasts, and we've historically sort of underperformed in almost every metric. So one of the premises and rationales for Matter is that we have an opportunity to change that, and that this is sort of a moment in time due to a variety of reasons where we really do have the opportunity to change that and create the ecosystem that will allow us to excel in translating innovations into companies and the growth of companies in an entrepreneurial ecosystem. Is there a second part of your?
No, that was, so we lied.
Or catch up.
Well, we have a lot of opportunity.
Anyone else, any closing comments? If not, thank all of you, thanks to our hosts, and I guess we're done, right on time.
I'd like to thank everybody for coming tonight. It's wonderful to see so many people here to hear the thoughts and the expertise from this terrific panel. Please join me in thanking Steve Gould again for putting the panel together. Special thanks to both Steve and to Eric, who have been longtime friends, supporters, cheerleaders, teachers for Sinai, thank you. And to John and Scott and Steve, you are now never going to get rid of us, so we're glad that you're going to be working with us. So thank you very, very much.